and let the people creep in from the coffee room. So may I request now, Dr. Kapoor, would you be able to stand here or you'll keep sitting? Somebody should come and help. I will sit from here. You can sit there. Okay, let somebody help him to come to the stage podium. So Dr. Kapoor does not require any major introduction. He is a very important echocardiographer for Apollo Hospital, Delhi. He has been with Apollo since, I think, the beginning. He has done, I think, more than 1 million echoes. How many echoes you must have done? And echo is a very important modality in the diagnosis of heart diseases, especially valvular heart disease. We all know heart contains valves and then coronary arteries and myocardium and then of course pediatric heart disease. So this session is actually on valvular and congenital heart disease, and this will have 3 talks. First by Dr. Kapoor, who will cover the clinical aspect and echocardiographic aspect of valvular heart disease, especially mitral stenosis or aortic valve disease, mitral leakage, how to diagnose clinically and of course echocardiographically, because we all depend upon echo to diagnose valvular heart disease. After that, we'll have a session by Dr. Manisha Chakravarti, who is a pediatric congenital interventional cardiologist in Apollo Hospital, Delhi, and then followed by a talk by Dr. Jyoti Muthu, who will talk about the surgical aspect of tetralogy of fellows. So let us give a good round of applause for Dr. Kapoor, who has come all the way. He has been with IECR since the beginning. He came to our Vigyan Bhavan conference. Then he gave a talk in London, Paris, Amsterdam. Recently he had some spine problem. That's why he's not able to stand that well, but he will recover soon. I think after his problem, this is the first talk he's going to give. Thank you very much for coming.
Thank you. Thank you, Dr. Vivek Gupta, for giving me an opportunity to speak on this topic of this valvular assessment by echocardiography. Now, I mean, it is just a saying that 2D echocardiography and color Doppler, they are the most cost-effective, they are easily available as well as portable methods for the complete evaluation of cardiac valvular lesions. And you can see this mitral stenosis here. This is a moderate MS, and you can see on 2D and you can see it on color, the turbulence as the blood flows from the left atrium to the left ventricle. And this is the mitral valve orifice area, which you can do by 2D planimetry as well as by 3D planimetry. So generally speaking, the 3D planimetry is more accurate because you know exactly where to take that area from. Because this valve domes, and therefore you have to take it at the tip, and right at the tip, and you have to be parallel to the plane of the mitral annulus. So therefore, the 3D is more accurate, and generally it gives a low reading as compared to 2D orifice area. So if you have a mild mitral stenosis, the orifice area is between 1.5 to 2.2 centimeters squared. If it is a moderate mitral stenosis, it is 1 to 1.5 centimeters squared. And if it is a severe MS, it is less than 1 centimeter squared. Now there is another method to calculate the mitral valve area by the continuity equation. So what you do is you take the LVOT diameter in the parasternal long axis view, and 0.785 d squared gives you the cross-sectional area, which you multiply by the LVOT VTI, and that gives you the stroke volume. The stroke volume divided by the VTI across the mitral valve itself. That gives you the mitral valve area in centimeters squared. And this is useful especially in those patients who do not have significant mitral regurgitation. So, and there is yet another method by Doppler that is called the pressure half time. And that is the time taken for the peak pressure gradient to drop by 1/2. The velocity of the pressure half time is given as V1 by square root of 2 or 0.7 into V max. And the mitral valve area in centimeters squared is 220 divided by the pressure half time. And in this particular case, 220 by 171 gives you 1.28 centimeters squared. So going purely by the pressure half time, a mild mitral stenosis is a pressure half time between 100 to 150, a moderate mitral stenosis 150 to 220 centimeters squared, and a severe mitral stenosis is more than 220 centimeters squared. Then you have a PISA method by which you can take the mitral orifice area, but actually we don't use it much. It's a little complicated, requires some expertise to do it, and takes time. So in the interest of saving time, generally we do not prefer to use this method, so I'll not speak in much detail about it. Then of course you take the pressure gradients. It's always better to take the mean pressure gradient, and this can be measured by tracing the dense outline of the mitral diastolic inflow that is shown over here, and the mean pressure gradient is automatically calculated. The mean pressure gradient, if it is less than 5 is mild mitral stenosis, 5 to 10 is moderate MS, and a severe MS is the mean pressure gradient less than 10. But you must understand that these gradients, they go on changing. And for the same orifice area, there could be these multiple gradients. So therefore, you have to see what are the hemodynamics. If the cardiac output is very low, then the mean pressure gradients will be very low, although the mitral stenosis is tight. And similarly, these mean pressure gradients will be very high if the patient has a high cardiac output state. Now you have to also measure the PA pressures. If there is a significant pulmonary artery hypertension, then the patient goes into pulmonary hypertension, which is both due to a passive pulmonary hypertension and as well as there is a vasoconstriction of the pulmonary arterioles, that is a reactive type of this pulmonary hypertension. So if you have a PA systolic pressure of more than 70, that is taken as severe pulmonic stenosis. Now this is mitral regurgitation. You can see that the inflows, this flow from the LA to the LV, these blue colored signals in systole, these are the flow signals of mitral regurgitation. Now you can compute the severity of this by these multiple methods, and the most common method that we have been using over the last several decades is actually to planimeter this mitral valve area in whichever view we get the best and compare it with the left atrial area. So if you have the regurgitant jet area of the MR jet, and if you compare it with the LA area, if it is more than 40%, then it is considered a severe. But nowadays we are using other methods to actually compute the severity of mitral regurgitation, and that is the vena contracta. Now this vena contracta is the narrowest portion of the jet as it goes from the LV to the LA, and just on the LA side of the mitral orifice. So if you take the width of this vena contracta, if it is more than 7 millimeters, it is severe MR, and less than 3 millimeters is mild MR. Similarly, you could use the PISA method. I'll not be going into the depths of the PISA technique, but suffice to say that we take the flow acceleration that is on this proximal side of the mitral valve. Now this actually is a transesophageal echo, so the LV is down and the LA is above. So therefore you are seeing that flow acceleration, and you are taking the radius of the flow acceleration 0.97 centimeters, and we are taking the mitral regurgitation Doppler spectral trace that is above the baseline, as you can see. And therefore you can use this formula of 6.28 R squared into the first aliasing of this pizza and divided by the peak velocity of the MR jet. That gives you the effective regurgitant orifice area, and if you multiply the effective regurgitant orifice area by the VTI, that gives you the regurgitant volume. Now there's another method you can use, is to see the flow in the pulmonary veins. Now it may not be possible all the time to see this pulmonary venous flow on transthoracic echo, and may require transesophageal echo. But whatever the method used, if you can see the flows. Now what happens in the case of this severe MR is that you lose the antegrade systolic flow, that is S wave, and that is replaced by the systolic regurgitant flow, which is labeled here as SRF. So if you get a systolic reversal of flow in the pulmonary veins, it is consistent with severe mitral regurgitation. Now you come to aortic valve, and you take the aortic stenosis. If we begin with, generally the aortic stenosis jets is eccentric, and the acoustic windows also may not be very good. So you have to use these multiple windows, starting from the apical plane, and then the right parasternal plane, the suprasternal plane, the left upper parasternal plane, and the subcostal plane, and you'll get the Doppler spectral, and take the best Doppler spectral tracing and calculate out the mean gradients as well as the VTI and the valve area, which you get by what is called the continuity equation. The aortic valve area, as shown diagrammatically here, is the LVOT cross-sectional area multiplied by the LVOT VTI divided by the aortic valve VTI. So that gives you the, and the ratios of the VTIs is actually the ratios of the peak velocities. So you can shorten this formula to include just the peak velocity of the LVOT divided by the peak velocity across the aortic valve. And you can also take what is called the velocity ratio. That is, this velocity in the LVOT divided by the velocity across the aortic valve. That is called this velocity ratio. And accordingly, you can get the valve areas. I'll have to take a little more time, please. So you get the aortic valve area by 3D echo also. You can get a cross-sectional view, which is called NFAS view, and you can get the aortic valve. This is by the transesophageal 3D. So you can directly planimeter it on 3D, which is little difficult to do on 2D. And thereby you can get the mean pressure gradients, this velocity ratio, aortic valve, peak velocity, aortic valve area, all can be done. And you can get the aortic valve area. If it is less than 1, it is severe aortic stenosis. A peak velocity of more than 4 meters per second, a velocity ratio of less than 0.25, a mean pressure gradient of more than 60, and an indexed aortic valve area of less than 0.6 centimeters squared per meter squared is actually severe AS. Now we can also do actually this is not playing now. It was playing very well actually. I checked it many times. Anyway, yeah. So you are getting the AR jet, you can see over here. So we are now looking at aortic regurgitation. And what we used to do earlier was to look at the jet width. That we have been doing for last 20, 30 years. What we have been doing is to look at the jet width at the origin and compare it with the LVOT width. But now we've got other methods, that is the vena contracta, this PISA, and we can also use the volumetric method by this conventional Doppler and regurgitant fractions. So you can see over here the aortic jet width or the aortic height. This is how we actually calculate the jet width, which is also called the jet height, and compare the width as compared to the LVOT. And if it is less than 25%, it is grade 1, 25 to 46 is mild or so, that is actually mild to moderate, to 25 to 46%, 47% to 60% grade 3, and grade 4 is more than 60%. So this is the vena contracta, which is the narrowest portion of the jet as it escapes from the, across the aortic valve into the LVOT. So you take the width of the aortic regurgitation. Mild is less than 3 millimeters, a moderate is 3 to 6 millimeters, severe is more than 6 millimeters vena contracta. And similarly then we can use the Doppler methodology to actually calculate the regurgitant volumes. Just taking the basic principle that the flow across the regurgitant valve is called the total stroke volume, and the flow across the normal valve is called the forward stroke volume. So the regurgitant volume is the total stroke volume minus the forward stroke volume, and that divided by the total stroke volume gives you regurgitant fraction. A regurgitant fraction of more than 50% is considered severe. A regurgitant fraction of more than a regurgitant volume of more than 60 ml is considered severe. And then you can take the backflow in the suprasternal notch, and the span diastolic backflow, if you get, that indicates severe AR. You can also use the pressure half time. A pressure half time of the AR jet of more than 400 milliseconds indicates mild AR. A pressure half time of less than 200 milliseconds indicates severe AR. Now you can also have this TR jet, and you want to actually measure the severity of tricuspid regurgitation. So you can use the jet area method. If it is more than 10 centimeters squared, it is severe TR. Then you can use you can also use the vena contracta, you can use the PISA, and you can get a good quantitative assessment of TR jet. Now the TS actually is, you take the mean pressure gradient across the tricuspid valve. If it is more than 5 millimeters of mercury, then this is severe TS. And if you take the VTI across the tricuspid valve, if it is more than 60 centimeters, it is severe TS. A pressure half time of equal to or more than 190 milliseconds is severe TS, and by continuity equation, valve area of less than 1 centimeter squared is also severe TS. Now you come to PS. Actually for PS, you know, this is simply that if you get a peak velocity less than 3 is mild, 3 to 4 meters per second is moderate, and more than severe is 4 meters per second. Then you have the peak gradient of less than 36, 36 to 64, and more than 64. And a valve area, if you are able to calculate by continuity of less than 1, then that is also severe PS. Now you come to PR, you can see that a pressure half time is one of the good methods. Shorter the pressure half time, more severe the PR. A PR, if this pressure half time is less than 100 milliseconds, it indicates a severe PR, and if you have a jet larger than 50% of the pulmonic valve annulus, that is also severe PR, and if a jet width is more than 65% of the RV outflow tract, is also severe PR. So this is how we actually estimate the severity of the PR jet. So we have covered all the 4 cardiac valves. Thank you very much for your attention, and sorry for exceeding my time.
Thank you very much. May I request, it's a very important talk, and you have done a great justice to the title of the topic, and we'll just request you to take your seat on the other side, and may also I request Dr. S.N. Pathak to be just on the dais to further let the session go. So we have another talk, important talk by Dr. Manisha Chakravarti, who is an interventional cardiologist, pediatric in our hospital in Apollo, and doing a lot of interventions to help the child or children save lives. And these are very important and tricky situations, because doing intervention in small pediatric or infant or child is not easy, and that actually takes away not only life-saving, but of course the LAs, the anxiety of the parents. Once you are a parent, you know if you have a child or hold or stenosis or whatever, then Dr. Jyoti Muthu and Dr. Manisha Chakravarti really help the families, and they have done a lot of many work. And I will request Dr. Manisha to also introduce a little more about herself and then go for the talk. Thank you very much.